Jacinta?
She can't hear
Can
us.
you hear me?
We can't, but we
Yes.
can. Yeah.
Yes. Are we sharing?
Can you send her a message to say yes?
Yeah. You can hear us, Jacinta?
No, she can't.
She can't.
No, the microphone's off.
Good morning, my name is Jacinta, and I would like to take this opportunity to thank Dara and everyone from HHT to invite me to speak today. Very hard act to follow, there, Dr. Saul and Michael. So I don't know if you can see my slides.
Not yet.
So today, as you know, I've been asked to speak on HHT, and as Dara said, I've worked in the National Maternity Hospital as a haematology midwife for nearly 22 years, and I had met a few patients during my time with HHT, and from the very first time I met my very first patient, I didn't know what HHT was, so I went off to investigate and to learn about it. And it's actually fascinating, but I know you all know it's fascinating, but from a healthcare practitioner, it is. So I suppose, so you all know in the room that HHT is an inherited genetic disorder that affects the blood vessels and is often known as the Osler-Weber-Rendu syndrome, or versions of that name. So you will find when you as a person goes into the hospital, the healthcare practitioner might not know HHT as you know it, but they might know and they might have heard of the Osler-Weber-Rendu syndrome. So just be mindful that you as the person that has the HHT often knows more than the health care practitioner that's looking after you in the general hospital. Okay, so you know, I suppose that you have some blood vessels that aren't developed properly and sometimes cause bleeding, again known as the AVN malformations. Again, you know this and you're very familiar with this, so just be mindful that when you go into the hospital, well, the doctors, you know, it is one of the rare diseases, and I think there's 8,000 and more, and so just be mindful, you probably know more about it than they will do. So your symptoms, of course, as you know, are regular nosebleeds, and the visible red spots, the telangiectasia and the AVMs. Now, I know you know this, so I suppose what my talk today is hopefully to know that what's the difference between, say, your HHT symptoms and pregnancy-related symptoms. So in pregnancy, I want to go back to the previous slide. In pregnancy, you often can get regular nosebleeds. So what I want, I suppose, you to do is, as the female or the person that's pregnant, is to just know if you get regular nosebleeds, you know, is it from one nostril, is it from both, how often do you get them? So just all this information that you can gather from yourself without, you know, writing it down, without taking notes, but, you know, if you're aware of how often you get nosebleeds, so in pregnancy you might get more nosebleeds, so that's when you do something about it, because that's not normal for you. So for the majority of people that are pregnant, they often, when they're pregnant, they often have regular nosebleeds, or have gum bleeding. So that could be pregnancy related, doesn't mean they have HHT, doesn't mean because you have HHT that they're not related. So just be mindful that you know what's normal for you, and then when you are pregnant, that if it's not normal, this is normal, the occurrence of your nosebleeds and all that you do something about it and don't just say, oh, it's because I have HHT. Is that okay? So on to the next slide. So as you know, there's no cure for the HHT, but there's very effective treatments, and from your previous speaker, I mean, there is just fantastic. It gives you great hope, and you know, there's simple procedures. And I would just say, I know it's not on the National Treatment Procurement Funds, but you know, the next time your politician is knocking at your door, these are the things you need to be telling them about. And you know, you're not alone in this thing. If you look at your statistics and look at your numbers and look at all the people that aren't on your register, I mean, there's something that your politicians should probably know about and can get, you know, put in the word for your procurement and get, look, that's a fabulous service that Dr. Soul is offering you. So just, you know, I suppose to be mindful. Anyways, back to what I'm here for today. So there's an increased risk of during pregnancy for women with HHT, and slight increased risk of major bleed and stroke. Again, in pregnancy there is that risk because your blood volume and all that increases. increases as your pregnancy goes on. But just in relation to the HHT, again, you have that slightly extra risk, and every baby has a 50% chance of receiving the gene. So physiological changes in pregnancy, again, I'm not going to give you a huge biology lesson here, but your circulatory system includes an increase in your cardiac output by 30 to 50%, and this is for everybody, not with any condition, but not with HHT, and your blood volume increases by 50% on average as the pregnancy goes on. Progesterone then, your levels, both your estrogen and progesterone levels rises in pregnancy, but it can increase your venous distensibility. So the collective effects of these factors can often result in enlargement and the rupture of untreated pulmonary AVMs during pregnancy. Again, if you know you have an AVM, you're coming to us with huge information. When I say us, I mean the hospitals in the country. Your increased risk of pneumothorax, hemoptysis, ischemic stroke, and pulmonary deterioration. Again, they're all risks of pregnancy, and again, they're just a little bit heightened if you have a condition. So, I'm just going to go through the path of a pregnancy, really, and getting pregnant. So, I suppose preconception. So, if you're going this path on your own, are you going in a same-sex relationship or in spontaneous, or you're going through infertility treatment, the more information that you can bring to the table, the better it is for the person that's dealing with you and looking after you and all that. So, I suppose your hormonal replacement and all that, your hormonal therapy isn't affected by your HHT unless you have another condition that may be affected by it. But again, I suppose if we don't ask the right questions, we won't get the right information from you. So, for example, if I say to you, has anyone else in your family got HHT, and you say no, what my question should be is, has everyone in your family been tested, and are the results negative? So just be mindful, if somebody asks you the question, like my first question, to be mindful that you answer it in that, well, no one has it because no one's been tested, or no one has it and everyone's been tested. They're two different pieces of information. Information about yourself would be, again, do you have any AVMs? Do you have any known AVMs? Do you have any bleeding? If you have you been treated? Where have you gone for your treatment? When was the last time you were treated? And how has your treatment been, affecting, how has it affected you? Have you had any embolizations of your AVMs? When have you had them done? Where did you have them done? Any vascular laser treatment, again, have you had it done? Have you had to repeat it? And again, where was that done? And kind of the years. They don't want a specific dates, but if you have your years and all that, it's just great information to have. I think with HHT, with any condition that you have, I would say don't say it as a bell around your neck. That that's here I come. See it as fabulous information that you have about yourself. I know this about me, and you're at a better standing than somebody that doesn't know. So use this information to your advantage. So now we're pregnant and we're coming through the antenatal clinic. So I suppose the more information that you bring to your clinic, again, the better it is for you. Now in Dublin, there's 3 standalone maternity hospitals. So they have no idea what happens outside their 4 walls of their hospital unless you tell them. Okay? Now, that's very positive because at least you know it's a maternity hospital, you don't know it. But if you were, say, down in Mayo, while you might be coming to, say, the vascular surgeon or the hematologist or the neurosurgeon or somebody in the hospital, when you're pregnant, you have a pregnancy set of notes which don't match your medical notes, and they will never meet unless you say, I have a medical condition, can I get my medical notes brought over? So again, if you don't tell us, we don't know. Okay? Again, if you're attending, say if you're coming to Mayo but you're attending any service in Galway, again, see if you can get the notes. So you can contact whoever you attend in Galway and say, can I have my notes because I'm pregnant and I'm attending Mayo? Or if you're in Cork and you're going somewhere different, or Waterford or whatever. So just again, the more information that you bring to the table, the better it is for us. Now, anemia. So I suppose everyone that's pregnant loses about 20% of their blood volume as the pregnancy goes on. So everyone is nearly everybody is anemic at some stage in the pregnancy. It's the severity of anemia that can be the issue. So some people have mild anemia, some people have more, and it's corrected. I suppose for somebody that has a bleeding issue, what you don't want to do is hide behind the bleeding issue, because it could be anemia of pregnancy rather than anemia because you have, say, bleeding. However, if your hemoglobin is low, you need to tell us, well, you know what, I had 3 nosebleeds this week. Okay, I have this, or I have piles and they're bleeding all the time. So whatever it is that your issue is, so just make sure that you're not blaming it all on the HHT, and also that we're not saying, oh, it's pregnancy related and it's not normal for you. So just be mindful that you have an open mind when it comes to that. And again, while you feel like, well, I was here last week or I was here 2 weeks ago, you might be dealing with different people every time you come. Now, in some of the hospitals in the country, there's 5 hospitals that have computerised systems that marry up against each other, but the rest of the maternity hospitals don't. So just be mindful that you're coming in, you might be coming into the same hospital, and the same thing, that if you're not dealing with the same person, just keep repeating yourself, okay? Coagulation, again, your coagulation, because all your factor levels rise in pregnancy, your coagulation factor levels rise, and your blood volume rise and all that, your coagulation in pregnancy is different than if you weren't pregnant. So again, to be mindful that, if you are bleeding, we need to do your clotting factors on you, and your basic coagulation on you, again, that you're not hiding behind the HHT, and someone says, oh, she has that, I won't bother doing the test. You need the test done. Is that okay? And again, preparation for labour. So again, I should come on to it in the next bit, but your pain relief, who do you need to see to get you through labour? So, if you have an AVM, do we need to know, if you have one, do you have one, where it is? Do you need to see, say, a neurologist? Do you need to see an anaesthetist in relation to this? And I'll come on to that in a minute in your labour, but who do we need to see to make your labour calm and, I suppose as easy for you as possible? And not that we're too, that we're intervening too much and all that, but we need to make sure the more information we have going into a situation, the better we are for you, and the calmer it is for you, and it's nice. And it is an exciting time for you. Well, I won't say labour is an exciting time, the process of it and the outcome of labour is nice. But anyway, so coming on to the labour then, again, if you have an AVM, we've got to talk about the pain relief that you can have. So can you have an epidural? If you end up, you'll say you might want an epidural, but in the throes of labour, your decision for wanting an epidural might be completely different than they were when you were 12 weeks pregnant. So again, if you're having if you're wanting an epidural, can you have one? If you end up having to go for an emergency cesarean section, can we give you an epidural, or do we have to put you to sleep? If we have to put you to sleep and under general anaesthetic, again, that comes with its own problems, and that comes with the conversation that it's easier to have antenatally than when you're on the way to the operation theatres. Okay. Mode of delivery, again, so again, just there, is it an elective cesarean section, or are you having an emergency cesarean? Well, you won't know if you're having an emergency cesarean section until the time. Can you have a normal vaginal delivery? Can you have an instrumental delivery? Is there any issues with having either? So again, these are the questions you would have if somebody is pregnant anyways. But if you have your HHT and you have issues around specific things, your AVMs or say anemia because of the HHT, we need to deal with this. And again, the calmer and the earlier we know this information, the better it is for you. So again, that's your most delivery. So postnatal, again, the postnatal care for anyone that's just had a baby, follows a path, and we make sure that you don't bleed, and postpartum hemorrhage and all that. Again, if you're being at a heightened aware, if you know that you have blood loss, again, if you have a blood loss that is a normal, and that is a normal for pregnancy, speak up. Okay, don't go off and think, okay, is this HHT, is this pregnancy? Speak up and we'll get to the bottom of it. You're better off speaking up and us looking after you than being at home panicking, because you've got to think there's you and the girl also have a small baby. come to us and it's very late in the day when, you know, it could be on the labour ward where they say, oh yeah, I think there's HHT in the family, or I think there's something else, and then we have to deal with what we have at the time. So again, postnatal, what we'll do is refer you, say we'll refer you down to Cork, or, you know, to your local general hospital and get all your scans, and then we can, or do your blood test and send you down to Cork then, whatever it is. So again, it's, the postnatal referrals are more to prepare you for the next time you come back to us. I know that's not a conversation we're having when you've just had a baby, but you know, it is something that we need to be talking about and setting the seat for you. So, is your pregnancy considered a high-risk pregnancy? So I suppose everybody that's pregnant, when they come to us into the hospital, and sometimes we will always get a letter from the GP, and the GP's letters can vary with, you know, loads of information to absolutely no information. So sometimes when you come to us in the 12 weeks, we have no idea anything about you, nothing about it except your name, your blood pressure and your weight. That'll be the end of that. Sometimes that's the extent of the information. So again, the more information that you can bring to us, the better it is for us. If it's on your referral letter from your GP, then you will get an earlier appointment, and it's more because, as I said, you know more about HHT than you will do. So say somebody that's reading this going, okay, what is that? Oh, I better bring her in. So you get an appointment then maybe earlier. You might get an appointment maybe at about 6 weeks, 7 weeks gestation to come in, so 7 weeks of pregnancy, to come in, and then you say, oh, this is what the issue is, and then Candace will ensue then after that. But it's just, don't get a fright if you get an appointment going, oh God, all my friends have been in at 12 weeks and here's me getting an appointment at 7 or 8 weeks. You know, don't be panicking. That's what it is. It's because it's in it, and we just need to see you beforehand. So is that okay? So risk stratification can be based upon results of the patient's AVN screening or treatment. Again, this is if we know you have the HHT. If you come in to us and you tell us you've had it and you haven't been screened, we will send you for screening, and then again, like I was saying, in the antenatal period, we will send you for the referrals everywhere. What we would prefer to do is send you to the anaesthetic department to see the anaesthetist, and then to turn around and say to us, everything's fine, you can go ahead with the epidural or spinal anaesthesia if you need it. Or we might send you to neuro if you had, say, an AVN in the brain, and they would say, you know, we'll have a shortened second stage of labour, so that means that you're not pushing for as long, say, as somebody that doesn't have the HHT. Okay, so again, these are things that will be discussed with you as an issue arises. There may be no issues, but if they do, they'll be discussed with you. And as I said, when it's done antenatally and it's all calm and it's, you know, a discussion rather than in the labour ward when you're huffing and puffing and we're saying, right, we have to do, you know, it does add to the stress and takes away from the enjoyment of the, you know, the whole labour and birthing experience that, you know, that you should be having. So unscreened patients and patients with known or untreated AVNs have a significant sign are at a higher risk. So as I just said, you know, we'll try and eliminate that risk, make sure we get our information up front and see what we can do in the pregnancy. So just in relation to Dr. Saul said, now nothing in comparison to her because she's fabulous, but you know, we could send you for a cauterization of the nose, you know, through our ENT services in say the hospital, general hospitals, or if you're in the standalone maternity hospital, they would send you to the ENT hospital in Donnybrook. So again, when you know what your issues are and you tell us, we will do something about it. Is that okay? So who should you refer to? So normally you come to, say, what we call a multidisciplinary team. So with HHT, you probably know this yourselves, but you don't fall in under one person. You know, you probably fall in under the hematology service for the injury, you fall in under vascular because of the AVNs, you can fall in under the neurologist again, you could fall in under respiratory. So everyone has a bit of you. So when you're pregnant, normally we'll deal with the pregnancy and then we'll send you off here, there and everywhere. So, you know, as I said, all the different departments. There are, in most hospitals now, what they have is a maternal medicine clinic. So it used to be called a high risk clinic, which scares the life out of everyone, staff included, when you say high risk, because you know it I suppose it is high risk. You're a higher risk rather than a high risk. So again, keep it calm. You know, I'd say keep it country, but we're not doing. We're on a different show today, but you know, who would refer to? So at the multidisciplinary team, you always have your obstetrician, you have your anaesthetist, you have your haematologist. They're nearly the core group at a maternal medicine clinic, and then they will send you for a referral, as I said, to the different other people, and then they will come back, but it'll be the same core group of people that will be looking after you. You tend to have, say, continuity of care, and by that I mean you nearly have the same consultant seeing you, say, at all the visits. Okay, I suppose I don't want to frighten you. You know, with HHT, as I said, it's great that you know it. You come with your information. You're in charge of it. You know, you give the information, but don't be shy in giving it to everybody every time you come. Okay, and I know you're probably saying, look, I've got to see my GP. I've seen him since, you know, I was born, and I'm 35 now. It's not that he doesn't remember you. He knows you. He's probably heard that information, and it's stored in the back of his head. So again, it's no harm just to say, don't forget to mention my HHT when you're referring me to the hospital. Is that okay? So there's some references to look at, but you've probably already read them and know more than me about them. And I'll just say if there's any questions. And again, thank you very much for letting me speak today. And very hard act to follow for the two previous speakers. Okay.
So I think maybe to handle the questions in the room, if anyone has any, Michael, would you unmute, ask the question to the call, and then remute again? So we'll try and limit the echo. So okay. Any questions in the room? And Michael will read them into the mic.
We thought we'd cover the subject just because. No, not gonna work.
I have a question, so
Okay.
Right, I'll turn this down.
You have to stand there and turn. He turned it on.
sorry, it's a manual process. Sorry? It's a manual process. It's a manual process. Is it?
Can you answer your question and then we try it out?
I think so. Is that working now? That should be working. So my question was, if there are no questions, where is the best resource for getting answers to questions? Because somebody who's maybe not asking a question today, or someone's related to somebody that is here today wants to ask a question. Do we have a lot of the questions and answers on a particular section on a particular website?
We do not necessarily on this topic. So if people have questions at home, or they can email us, and we'll refer back to Jacinta, and we'll put the questions and answers up on our website. At the moment we don't have any questions and answers related to maternity, but here now in the chat room, I think in the Zoom room, no, but here in the physical room, Marie has a question.
Yeah, sorry Jacinta, I was just curious, you said something about people with brain AVMs, that if they're pushing, that you stop them pushing too hard towards the later stages. What do you do? How do you do that?
Just put the microphone on.
What we would do is, and I hope I won't be turning you all into midwives now at the end of the day, but we actually could do it if you're more on the floor. But what we would do is, say, when somebody is fully dilated, you give them an hour nearly from fully dilated to, say, delivery of the baby. You try and get them to, you know, can you still hear me?
Yes?
Yes.
Can you still hear me? Yeah. So what we do is we would get them to deliver, but if somebody would say with HHT and say they had an AVM in the brain, what we wouldn't want to do is put too much pressure on. So we would let them say maybe for the head to come down. Too much information for you for today, but we wouldn't probably start pushing, and then we might get you to push for say a half an hour. But at that point we would have discussed then maybe the need for an instrumental delivery to assist mom with the delivery of the baby, or if the baby went into distress, then again you go to a section. So for most people without say an issue, you would get them to push for an hour. For people with an issue, you know, it'd be a half an hour, but you wouldn't necessarily get them to push the minute then we find out that they're fully dilated. So you kind of wait and let the body do the work for them. It's just you don't want to put too much pressure on them. to finish, if anyone did find out today, when they were told today that they were pregnant, I don't want you to panic, you know, keep it calm, and it's great news, and just, when you make your appointment, the more information that you send in on the GP letter, or even if you fill out the form yourself, and the more information you bring to your appointment with you, and I'd say appointments with you, there's nothing wrong with repeating and repeating and repeating yourself, because you are meeting, say, there's a high chance you might meet the same people if you go to maternal medicine clinic, but if you go to, say, a different clinic, you know, you are meeting different people all the time. And again, if you're in the hospital, general hospital, and you're going down for your HHT, and you're going to a different area in the hospital for your pregnancy, don't assume they know. Okay, so come, you have the information, it's fabulous that you know this, you know, you bring that information with you and tell us. Because the more times we hear it, you know, it, I won't say it doesn't sink in, but, you know, we get it. So don't assume, we know, and also don't assume we know about HHT. So just make sure that, you know, you tell us your symptoms. You know, if you get a nosebleed once a month, you get it twice a week, what is it that's you? And then you know if your new symptoms, your pregnancy symptoms are different than your normal HHT symptoms, do something about
You
it.
have a question? Okay.
Okay.
We've
Okay.
two questions in the room, I think.
Hi, just in relation to say mums who don't have HHT.
Hang on.
Sorry?
Michael, until if that's muted, she won't hear.
Okay.
So I'll turn this down.
I can't hear.
We can hear.
No, she's saying she can't hear.
Can you unmute there, Michael?
Yeah, Kev, you ready?
Okay.
Hi, just in relation to mums who don't have HHT, but say the dads do, the child has a 50% chance of having HHT, and in the womb, like the baby could have like brain AVMs. So, is there any up to date like information on that?
It may not be her.
I can hear somebody talking, but I can't hear the actual words. Do you want to put it into the chat, and or if somebody up the front can ask the question in the microphone?
So I think that would.
Yeah, but
If I turn this on, Jared asked the question here.
Yeah.
If you can speak towards the microphone.
Hi, can you hear me? Can you hear me?
Yeah.
Can you hear me?
She said it might have
Oh,
us on mute. She might have us on mute.
No?
Oh, we can't hear
Okay.
her.
Maybe a WhatsApp or microphone.
Can you hear me?
Oh,
Yeah.
Yes. Can you hear me?
Just a question that's come up here. If the baby in the womb has HHT, the worry is a brain AVM. I don't know, is that a question? or
It's just
is it-
if the mum doesn't have HHT.
No, what we would do is once the baby is delivered, what we'll do is refer you to Cork, or if you're known to Cork, then they will follow up and do the genetic testing onwards. But no, it should be the mom's AVM.
okay. I don't think she caught that question. I will give it to her.
If mom doesn't, so this is like any person with a bleeding disorder, if mom doesn't have the HHT but dad does, what advice would we give? So for the mom, she can have, say, her epidural, she can have her IM pain relief, so she can have everything. Again, what we do is you'd ensure the safe delivery of the baby, but we would do this with everybody. So again, it'd be referred afterwards for the baby. So even forget the HHT with any bleeding disorder or anything like that, and the dad has it, because the dad then can pass it down to obviously to the babies, to the baby or babies. It'd be the baby that have the issue. So what we would do is send the baby for the referral then afterwards and let Cork know of the delivery. But we wouldn't, there'd be no extra precautions required for the baby, and then mom in that case needs to have can have everything that she wants. The baby would have a day 1 and day 2 check with the paediatrician in the hospital. So this would be routine care for every no harm for the, you know, you would say, well, the dad of this baby has HHT, and then the paediatrician can send the referrals.
If he scans under the baby, the womb.
What risk is there for the baby before delivery? No risk for the baby before delivery. The risk for the baby before delivery, or the risk for any baby before delivery, and that would be, say, if the mom is anemic, again, the risk maybe because baby might get enough food. So to make sure that you're on top of your anemia, but this is pregnancy related rather than HHT related, yeah? So again, all the risks that happen to the baby would be, I suppose the baby's at no extra risk because of the HHT in the womb than any baby, okay? Is the baby scanned in the womb for AVRs? No, well, I'll say no. The baby will be scanned, the baby will have a routine scan at 12 weeks to confirm the pregnancy and to confirm that there's one baby as opposed to two or multiple babies. And then the mom will have a scan at 20 weeks, which we call a daily scan and anatomy scan, where they measure all the baby's bones and, you know, they measure the size and they measure the lycra volume and all that. So they do on all the organs. That's, you know, the big scan. If anything unusual comes up there with the baby, forgetting HHT, anything unusual comes up there in that baby, then the baby will go to what we would call a fetal medicine specialist, who would be in conjunction with a maternal medicine specialist. So fetal medicine specialist would be specifically for fetal medicine. So they would probably have to go, not probably, they would have to go to Dublin, to one of the 3 maternity hospitals in Dublin for the fetal medicine specialist clinic. So it may be a once-off visit that they would go up there, or maybe, I suppose the other extreme would be that they'd have to continue their pregnancy and complete their pregnancy in Dublin. So again, if anything happens with the baby, if there's any abnormality seen with the baby at scan, then the babies would be referred to a fetal medicine clinic. Forgetting HHT, this is just right across the board for everybody. So I hope that answers your question. It's not that they're not scanned for the AVMs. If anything is seen, and they would be examined thoroughly, if anything is seen, then they would be referred to the fetal medicine clinic.
Okay.
Is that okay?
Thanks, Jacinta. Could she hear me?
No.
No.
Yes, can you give our thanks from everyone in the room to Jacinta?
Okay. So she can
Everyone happy?
hear us. Yes. How do you say goodbye?
Yeah.
Technically, too. Bye, Jacinta.